All right. Well, let's first just real quick go over the purpose of our case studies. First of all, it just gives you good training on the use of the definitions, and these are all based on the new January 13 definitions. Try to learn to accurately apply these definitions and to realize these are surveillance definitions and can get very consistent in our application and improve our data quality. And I was just speaking with someone during the break, and I think when we roll out all these new definitions, and we've been talking a lot about validation of denominator data, I think it's really good when you move this many kind of new definitions. It's good to get with someone when you're your numerator as well, and when you're starting to write up these CAUTIs, based on new definitions, just have someone you can sit with and validate, say, do I've got this right? But hopefully going through this will help you. All right, let's start with case 1. Day 1, we have a 50-year-old patient with end-stage pancreatic cancer with liver and bone mets admitted to the hospital with advanced directive for comfort care and antibiotics only, a Foley catheter, a peripheral IV, and nasal cannula inserted. On day 4 now, the Foley is still in place. The patient is febrile to 38.0 centigrade, has suprapubic tenderness. IV ampicillin was started after a urine was obtained for culture. Day 5, the patient's having difficulty breathing. The chest x-ray shows an infiltrate in the left lung base. On day 6, those urine culture results are back that were taken on the 4th, and it shows 10 to the 5th of E. coli. Day 7, you've got WBCs of 3,400, patchy infiltrates in both lung bases, continued episodes of dyspnea, rales in the left lower lobe, and on day 11, the patient expired. Does this patient have a UTI, and if so, what type? Yes, a SUTI, criterion 1A. You can get your definitions there kind of in front of you. There was the SUTI page was cut and pasted on there. A yes, SUTI, criterion 2A. Yes, an ABUTI, or no UTI. Go ahead and use your clickers. This is to vote. All of mine are voting questions except the last 2, I think. All right. We're getting there. I need a few more responses we're waiting for. You can see there's some group consensus going on at tables. Good discussion. All right, I'm going to give you about 10 more seconds. I don't use the little timer, but I'm going to close the polling in about 10 seconds, so go ahead and get those responses in. See, I can see how many of you have voted. I have a little magic screen here. All righty. And the answer is yes, they have a SUTI 1A, okay? And we're going to go through and show you the rationale. You all did great on that. So I have that page right in front of me there. The catheter had been in place for greater than 2 calendar days, suprapubic tenderness, and greater than 10 to the 5th colony forming units. See, that wasn't so hard, right? But that fever that she had, that was only 38. It was not greater than 38, so you had to use that suprapubic tenderness. All right, case 2. On 8/2, a 66-year-old went to the OR for an exploratory lap, and a Foley was inserted in the OR, and they were transferred to ICU post-op. On 8/3, the patient was stable, Foley still in place. On 8/4, the patient was noted to be febrile to 38.9 and complained of diffuse abdominal pain. The WBCs were increased to 19,000. He had cloudy, foul-smelling urine, and the urinalysis showed 2+ protein, 1+ nitrites, 2+ leukocyte esterase, WBCs of 10,000, and 3+ bacteria, and the culture was 10 to the 4th colony-forming units of E. coli. The abdominal pain seemed to be localized to the surgical area. Is this a UTI? And if so, what type? Was there no UTI? Yes, it was a SUDI criterion 1B. Yes, a SUDI criterion 2A. Or yes, an ABUDI. Place your votes. All right, I'm going to give you about 10 more seconds. Make a decision, place your vote. Okay. Yes. Look how well you all are doing. 90% of you got that one right. Yes, this is a SUTI criterion 2A, and we'll go over that. So remember, 2A is where you have the little bit lower colony-forming counts, but the patients had a Foley in for 2 days, had the fever that was greater than 38, had the leukocyte esterate and the nitrite positive. Remember, the leukocyte esterase points to the fact that there may be some WBCs in the urine, and the nitrite points to the fact there may be some bacteria in the urine, if that's fallen off your radar of what that means. Pyuria was present, and also we then had a urine culture that was 10 to the 4th, so that's why we went to the criterion 2A, and why we needed a little more evidence that was found there in that urinalysis, okay? All right, case 3. Day 1, you have a 58-year-old patient who's admitted to the ED with GI bleed and a Foley is inserted. Day 2, the patient spikes a temp of 38.6, the indwelling catheter remains in place, and a urine specimen is sent. On day 3, the culture results are back, and it's 10 to the 5th of Pseudomonas aeruginosa in that urine culture. Is this an HAI, and if so, what type? Yes, it's a UTI, but not a CAUTI because the catheter had not been in for 2 calendar days. No, it meets the definition for present on admission, or yes, it's a SUTI criterion 1A. Go ahead and place your votes. This first table's having lots of discussion. I'm enjoying this over here. All right, I'm going to give you about 10 more seconds. It looks like almost everybody has voted except this one troublemaking table over here. Okay, closing it off here. No, this meets the definition for POA, or present on admission. Very good. Let's go over that. An infection is considered present on admission if it occurs on the day of hospital admission or the next day. The infection must fully meet a CDC NICHN criteria on the third hospital day to be prior to the third hospital day to be POA, and this one definitely occurred. They'd only been in-house just that second day and they had the symptoms. Okay? All right, case 4. You guys are doing great. Day 1, an 84-year-old patient is admitted to an LTAC with a diabetic foot ulcer and an indwelling catheter in place. On day 8, so now we're 8 days later, indwelling catheter is still in place and there are no signs and symptoms of infection. Day 9, the patient becomes hypotensive. The CBC shows a WBC of 15,000, a temp of 38.0. The foot ulcer is draining moderate amount of purulent drainage, and the patient is pan-cultured. The blood culture and the urine culture both grow strep pyogenes, and the urine is showing greater than 10 to the 5th colony-forming units in that result. The foot culture is positive for Pseudomonas aeruginosa. Is this a UTI, and if so, what type? 1, no, because the blood seeded the urine, and therefore there is no UTI. Yes, it's an ABUTI, or yes, it's a SUDI criterion 1A with a secondary BSI. All right, I'm going to give you 10 more seconds. Maybe I should have had the unsure question 4. 10 more seconds. Give it your best guess. All righty. Very good. Yes, this is an asymptomatic bacteremic UTI. All right. And we'll go over the rationale for that. There were no signs and symptoms. Remember, that temperature was not greater than 38. It was 38 on the nose. And the positive blood culture has to have at least one uropathogen matching to the urine culture which the patient had. What if, this is part 2, the organism in both cultures, both the blood and the urine, had been Micrococcus? Is this a UTI? Yes, this is an ABUTI, or no, this is not an ABUTI. Go ahead and vote on that one. Okay, we're almost there. I'm going to go ahead and give you about 10 more seconds. Finish up your polling. Very good. No, this is not an ABUTI. And your rationale here. Micrococcus is not a uropathogen, and therefore this is not an ABUTI. Remember, you need to have the organisms have to be on that uropathogen list, and here it is again. And remember, that list is going to be able to be found in the NHSN manual in your ABUTI criterion section. It'll be right there listed, so that's helpful for you to remember, okay? Let's go on to case 5. On 8/5, we have a 76-year-old woman admitted from the LTAC at 8 a.m. for surgical debridement of a sacral decube. The medical history is notable for severe rheumatoid arthritis and congestive heart failure. A routine admission UA is performed. It's positive for leukocyte esterase and 3 WBCs by high-powered field of spun urine. The patient's afebrile, denies urinary urgency, frequency, or pain, and there's no suprapubic or CVA pain, and a Foley and a peripheral IV are inserted in the OR. The next day, 8/6, the wound care specialist documents that the wound is clean, temp of 37.4, and the Foley is draining some cloudy urine. On 8/7, the temp is 38.2 degrees centigrade, the Foley is removed, encouraged to push PO fluids, and a urine specimen is sent to the lab for culture and sensitivity. On 8/8, the temp is still 38.6, and the patient's complaining of dysuria and pain with palpation to the suprapubic area, and Bactrim is started. On 8/9, that urine specimen that was sent on 8/7, the results are back and are positive for E. coli 100,000 colony-forming units, and the patient is afebrile and preparing for discharge back to the LTAC. Does this patient have a UTI, and is it a CAUTI? 1, no, the UTI was present on admission. 2, yes, the patient has a SUDI-1A and it is a CAUTI. Or yes, the patient has a SUDI-1B, but it is not a CAUTI. Okay, I'm going to give you about 10 more seconds. We're looking close here, but about 10 more seconds. Finish your voting. All righty. Yes, you guys are doing great. This patient has a SUDI-1A and it is a CAUTI, and we'll go over the rationale. This all occurred on hospital day 3, it's been so greater than 2 calendar days, and she had fever and suprapubic tenderness, and the urine culture was greater than 10 to the 5th of colony-forming units. Now, the trick question there may have been that positive UA on admission, but remember, UAs may be positive for non-infectious reasons, and since symptoms of UTI were definitely not present on admission and only developed following Foley insertion, this would meet our definition for a CAUTI. All right. Let's go on to case 6. This is a 48-year-old male who's involved in a motorcycle accident, has a closed head injury, multiple fractures, taken to the OR for ORIFs and evacuation of subdural hematoma. A Foley catheter and a left subclavian catheter are placed in the ED, and the patient remains on the ventilator that was placed in the OR. The lungs are clear bilateral. Now, 6 days post-op, we've moved on here, and the temp is 99.8. You have some rhonchi in the left lung base. The chest x-ray shows a possible infiltrate atelectasis in this area. The Foley remains in place, draining clear yellow urine. Patient remains ventilated and has increased sputum production. Post-op day 7, you have a temp of 100.3. The vent settings are stable, and there's no change to the sputum production. Post-op day 8, the temp is now 101.9 Fahrenheit. The lung sounds are clear, chest x-ray clear, patient still remains on the vent, and the Foley and central line still remain in place, and pan cultures are sent. An empiric antibiotic treatment was begun. Post-op day 9, the urine culture shows 100,000 CFUs of Pseudomonas aeruginosa. The sputum shows Pseudomonas aeruginosa, and the blood culture was no growth. The physical assessment is normal, and the patient has no response to suprapubic or costovertebral angle palpation. Does this person have a UTI, and if so, patient rather, have a UTI, and if so, what type? Is there no UTI? Yes, it's an ABUDI. Yes, it's a SUTI 2A, or yes, a SUTI 1A. Okay, I'm going to give you about 10 more seconds. Couple more seconds and okay. Yes, this patient has a SUTI 1A, 87% of you. That's great. The Foley was in place for greater than 2 calendar days. You had that fever, had a positive urine culture with greater than 10 to the 5th colony-forming units with just the one single pathogen. Now let's put a little tweak to this. What if the patient had been afebrile, you didn't have that temp, but you had an elevated WBC and the urine was really cloudy, but the culture results were the same too? Would the patient have a UTI? No UTI, yes, still a SUTI 1A, or yes, and a booty. Yeah. This one? Yes. Someone asked if the elevated WBCs and the cloudy urine was the WBCs were in the urine, and the answer is yes. That was urine WBCs that were elevated. But the patient doesn't have a temp. Not that I'm giving you a hint, but. All right, 10 seconds. Oh, very good. No UTI, and the rationale on that, remember, this was a patient without symptoms. At this point, we took the fever away. Remember, they don't have a matching blood culture, so it can't be in a booty. And the elevated BC and cloudy urine are not part of our NHSN UTI surveillance criteria. But I can tell you, I can't tell you how many times when I'm investigating a urinary tract infection, you try to figure out why they sent this urine specimen, cloudy urine. Man, lots and lots of times you see that. Seems that that's why they're sending the culture, was because they saw cloudy urine. But that is not part of the definition. Remember, your surveillance definition can work better in some patient populations than others, which we've already talked about a little bit in terms of how they can respond to being able to express about different symptoms. And the patient should be thoroughly assessed for UTI symptoms, including that suprapubic tenderness and the CVA pain. And this is where it can be really helpful in terms of educating your nurses in terms of good physical assessments, or any of your clinicians. And again, that clinical diagnosis may differ from surveillance determination, and you may see often these 10 to the 5th being treated by physicians and called, but it doesn't meet our surveillance definition, because that to us is would have been, when you take that fever away, that would have been an asymptomatic UTI, which we don't document, unless it's in a booty. All right, let's do case 7. It's 825, and a 73-year-old patient in a neurosurgical ICU was admitted following a cerebrovascular accident. Ventilated, has a subclavian catheter and a Foley in place on admit, and the patient reacts only to painful stimuli. On 9/2, the WBC is slightly elevated at 12,000, temp of 37.4. The urine is cloudy, and the lungs are clear to auscultation. On 9/3, the WBCs are at 15,800 per cubic millimeter. temperature of 37.6, breath sounds slightly coarse, minimal clear sputum, urine unchanged, the blood and endotracheal and urine specimens are collected, and there's no suprapubic or CVA pain noted. On 9.4, blood and endotracheal cultures are no growth, and the urine is 10 to the 5th colony-forming units of Enterococcus faecium. Does this patient have a UTI, and if so, what type? Yes, they have an ABUTI. They have a SUDI criterion 1A, a SUDI criterion 1B, or no UTI. Okay, we just have 10 minutes left for our case study, so I want to get through all these. So let's wrap this voting up in 10 seconds. All right, here we go. Everybody. Really good. 88% of you, correct answer. There was no UTI. Because there were no urinary symptoms and there wasn't a fever greater than 38 and no matching cultures, the urine surveillance for UTI are not met. But let's give it a little tweak here. What if the patient's temp had been 38.1 and the patient also met the criteria? You saw that pulmonary stuff going on, had met criteria for a probable VAP, including a bronchoalveolar lavage with I'll have to change the organism here. With our new VAE criteria, we wouldn't have Enterococcus. I just noticed that. But we'll just say we did Enterococcus faecium. So you have the same organism now from the BAL as you do in the urine. So here's the new question. Does this patient have a UTI? No, the patient's fever is due to pneumonia, therefore the patient is symptomless. Yes, it's a SUDI 1A, fever is nonspecific, and may be due to more than one infection at a time. All right, 10 seconds because we're getting close to the end of the day. All right, here we go. Yes, because fever is nonspecific and definitely may be due to more than one infection at a time. Patient had a SUDI 1A, the indwelling catheter was present, the fever and the urine culture, and greater than 10 to the 5th of a colony forming units. All right, we have a 4-year-old admitted following an MVA, taken to the OR for ORIF and internal fixation of a left upper and right lower extremity fractures, admitted to the pediatric surgical care unit with a Foley catheter, draining yellow urine, and a right femur detraction, IV in the right antecubital vein. 8:18, afebrile, taking clear liquid diet and beginning oral pain med using incentive spirometer. The Foley's draining yellow urine. 8:19, next day, tolerating a solid diet. The IV is converted to a saline lock, Foley draining yellow urine. 8:20, the Foley is removed at 0800, and the patient is voiding without problems, and the patient has a slight cough of clear phlegm. 8:21 in the morning, the patient is requesting a bedpan frequently, crying with urination, temp of 37.9. The cough is unchanged, and a straight cath urine specimen is collected. The urine's cloudy, and the UA is positive for leukocyte esterase, nitrites negative, a WBC of 10 per high-powered field. Later that evening, the gram stain of the urine shows many gram-negative rods, and empiric Bactrim is started. On 8:23, that culture comes back, and it's 50,000 colony-forming units of E. coli. Does this patient have a UTI? No, or yes, a SUDI 1B, yes, a SUDI 2A, or yes, a SUDI 2B. All right, place your votes. 10 more seconds. All right. Yes, this is a SUDI 2A. If you look at that's that lower part of the definition, the patient had an indwelling catheter in place for 2 days. It had just been removed, and we had frequency and dysuria that she was complaining of. Leukocyte esterase positive. You had that 10 WBCs per high-powered field, and they saw microorganisms, and the organism result was between that greater than 10 to the third but less than 10 to the fifth. Well, we only have... Okay, we're going to go to the last couple that let you practice counting those denominators we were talking about. So let me get to those. All these cases are in your packet, and you'll have the answer sheets as well. All right, let's talk about counting Foley days for your denominators that we were discussing. So I want you to look at this, all right, and tell me how many indwelling catheter days you think you have. Look at the status. Everything was counted at 12 noon, okay, in this unit. And do you have 6, 5, 4, 3, 2, or 1 catheter days for that day on the unit? And this one is not this is not one you can vote on. So I'm just going to show you, but just, make your decision in your head what you think your answer is, okay? I'm going to give you a couple more minutes, but count was done at noon. All right. See, most people look like there's 2. And I'm going to show you where they are here. You have this one, patient 101, Mr. Black, had an indwelling catheter that whole day, and at noon, and 106 had an indwelling Foley at noon. Now, you might have thought there were 3, but look at the patient Salmon. They weren't admitted till 2 in the afternoon. So at noon, they would not have been there with a Foley. So those are the only two patients that at noon would have had a Foley. Okay, let's try one more. Okay, same thing. Now this is, again, another unit. How many indwelling catheter days do you see here? And this is a unit where they're doing their catheter counting at 11 p.m. Think you got it? Okay, here we go. See if you guessed right on this one. 1. Yep, looks like people are happy. It's this patient, Miss Dallas, is the only one. We don't count condom caths, and suprapubics don't count. And that other indwelling, they'd already been discharged. So we have 1 Foley catheter day that day. Great. Well, thank you very much.